Thank you. And welcome. Thank you for taking time to join us this morning. My name is Tracy Leonards. I am a consultant that works with the Arizona Department of Health Services Primary Care Office. I coordinate shortage designations, including health professional shortage areas. So I know I have interacted with many of you through that process over the years. I have with me Wes Cordum, who is our data analytics section lead at ADHS, and Nicole Iden, who is our GIS manager. We are going to be giving an overview of our primary care areas, which we are in the process of updating boundaries for. So we want to share today a little bit of background. That's what I'm going to do to get us started on what primary care areas are and how we use them for shortage designations. And then I will hand it over to Wes and Nicole to talk about kind of how they came up, the methodology behind the primary care areas, what those new proposed boundaries look like. And at the end, we'll talk about some next steps. Next slide, please. I should mention too that if you have questions along the way, please feel free to put them in chat. We'll be watching that, or just unmute yourself and ask away. We're happy to answer questions as we go. And if you, while you're not asking a question, if you could leave yourself on mute to kind of avoid any background noise, that would be great. Thank you. Okay, so the shortage designation program. Within the Bureau of Women and Children's Health at ADHS, we have our primary care office. This is funded by a cooperative agreement with the federal agency HRSA. And one of the components of our role as a primary care office is to coordinate shortage designations. These are areas or populations that have a shortage of dental, mental, or primary healthcare providers and services. There are a couple different types of federal shortage designations. One is a medically underserved area or population. That really just reflects primary care services. It's not updated, so many of those designations are quite old. And the main purpose that they're used for now is to identify areas that are eligible for new access points for federally qualified health centers or community health centers. The shortage designation that we talk about more frequently, and that I'll be going a little bit more in depth here, is health professional shortage areas, or HPSAs. Those can be for primary care, dental, or mental health. And just in the past year or so, they've added a new designation called a maternity care target area, or MICTA. Next slide. So HPSAs identify an area or a population as having a shortage of providers specifically. It's kind of used as a base requirement to qualify for a variety of state and federal programs that are really aimed at increasing health workforce. So that way we can make sure that those programs are really funneled to the areas most in need. HPSAs, if they qualify, which is basically based on a population to provider ratio and a few other things, if a community qualifies, then we submit an application, and HRSA, the federal agency, gives it a score, which is based on the level of need. So the higher score, the higher need. And those scores are used for funding preferences, priority in awards, award levels and amounts for loan repayment programs, placement for National Health Service Corps scholars, and not the score so much, but the designation status itself, specifically a geographic type primary care HPSA, is an eligibility requirement for bonus payments from Medicare. Next slide. So this is just an image from HRSA that kind of shows the breakdown of how HPSAs work. So as I said, HPSAs can be for primary care, mental health, or dental health. And they can be a few different types. It can be a geographic area. So we're looking at all the people and all the providers within a set geographic boundary. It can be for a population group. Here, we typically would do that for a low income population. So in that case, we're still using a geographic boundary, but now we're only looking at the subset of the population that's at or below 200% of the federal poverty line. and only the portion of provider time that is dedicated to that population. We calculate that using Medicaid claims and sliding fee scale percentages from clinics. We can also have HPSA specifically for facilities. That would be things like correctional facilities. They have to meet a certain provider to population ratio to qualify. Some facilities get an automatic HPSA designation. That would be tribal and IHS facilities, community health centers, and also rural health clinics, as long as they certify that they are utilizing a sliding fee schedule. Okay, next. So now kind of tying all of that shortage designation stuff into what we're here to talk about today. State primary care offices are required by HRSA to have what they call a SRSA plan, a state rational service area plan. These are basically breaking your state up into geographic boundaries that are rational, and those geographic boundaries will then be used as the boundaries for HPSA designations. Some states, like on the East Coast, have counties that are really small, and that's a very convenient, easy way to have a rational service area plan. Our state, not so much. That doesn't work here. So because that never worked for us, we were actually one of the first states to have a SRSA plan all the way back in the 1990s. We last updated those boundaries in 2013 with a GIS methodology that Wes created for us. And the intent of that was that we would repeat that methodology every 10 years when a new decennial census came out, so that we could adjust those boundaries to account for growing populations and shifts and things like that. We call our geographic areas, our rational service areas, primary care areas, or PCAs. Primary care areas are actually also in Arizona state statute, that we have those, and we use them for reporting on medically underserved areas. And then we use those PCAs as geographic boundaries for all of our health professional shortage area designations. Next. Okay, so this is where I hand it over to Wes, and he'll talk about our update of those PCAs.
Thanks, Tracy. Yeah, I'm going to give you an overview of where we're at with the PCAs now. It's been a long journey getting them here. Nikki, our GIS program, did a lot of work getting us to this spot, but we have used the past methodology and been able to apply it to the new data and come up with our new boundaries, and I'll show you all those here. So first off, what is a PCA? Well, primary care areas were built by ADHS in 2023, this version anyways. The last ones were 2013. But they're meant to represent where Arizonans go for primary care, while also representing communities with a population size conducive to spatial and statistical analysis. The representing communities with population of spatial and statistical analysis, that came in the last decade. When we did this, we were bringing together multiple geographic areas within the agency, and we're able to unify that, so we're all speaking with one voice and have one boundary set for showing the communities of the state. Okay, so why PCAs? So as Tracy just told you, there's a both state and federal requirement that we create these. And then, like I was saying, we also are using them for our small area and community analysis for the health department. So the state and federal requirements. So we're required by statute in connection with Arizona medically underserved areas, or biannual designation. And we use them as pre-approved rational service area plan for federal designations of HPSAs and MUAs and MUPs, just as Tracy was telling you. Okay, so now why PCAs for small area community analysis? So in Arizona, we have a lot of options to do small area analysis. We have gone through those and found issues with each one of them, starting with counties. We only have 15 of them. Tracts, there was 1,100 in 2010. It's like 1,600 maybe now. So there's way too many of them. It doesn't get to the community level, and the populations aren't large enough. Zip codes, people like to use those, but their boundaries change all the time, and they don't actually have an area. They're just mail delivery routes and post offices. And then cities don't cover the whole state. So we went through all the different possibilities and didn't find any existing geographies that really met this need. To bring that home a little bit, we can look at our counties. If we were Georgia, this wouldn't be a problem. I think they have 159 counties. Even Idaho has 44, but we have 15 with 65% almost of the population in one county. This tells us nothing about what's going on in Arizona's communities and is not very helpful in terms of helping Arizona's communities and getting them data and being able to know exactly what's going on there. So we created PCAs. And if you look on the left, you can see the 2010 PCAs. This is what we created last time. And then on the right, with changes in population, but using the same methodology, we ended up with what you see there on the right. Now, that's for the whole state. This is the Metro Phoenix area. Here's Metro Tucson. And we do have a link that I'll show you later that where you can explore this on your own too. So a little bit about the primary care areas and what we ended up with. So just like last time, they represent today's communities. We said that in 2013 when we built them, and we're saying that now for 2023 because they represent the data that exists today. They maintain populations conducive to statistical analysis. We made sure they all had at least 10,000 population, but not more than 200,000. They identify where people go for primary care, and they're built with a repeatable rule-based methodology. This allows us to keep consistent as much as possible over time. Obviously, we have consistency in every decade because we only have to change them once every 10 years when the census changes their census tract boundaries. We also have to change. It's a good thing to do as well because, as you know, Arizona is a fast changing state. So we want to make sure that our communities reflect the reality on the ground. Okay, so to do this, we have quite a few rules within the methodology. So first off, it has to be built from U.S. Census tracts. That is a federal requirement. So that's kind of done for us right there. Then we didn't want any PCA to be too large an area. That loses the community aspect somewhat. But we're still trying to balance our population minimums, and we have some very rural areas out there. So we set a minimum of 7,500 square miles, I'm sorry, a maximum of 7,500 square miles per area. Then for population, it can't be more than 200,000, and it needs to be more than 10,000 and less than 200,000, I should say. And we used existing political boundaries as much as possible to draw these, so it would be recognizable to everyone. So if you live in Tempe, you will have two PCAs, a North and a South Tempe. And then let's say you're in Flagstaff or even a rural area, we've tried to draw them around any boundaries that exist to represent those communities. And lastly, PCAs should not cross county lines. Now, it's a complex state, and there's a lot of needs for this particular geography, so there are some exceptions to these rules, most notably anything tribal. We wanted to preserve our tribal boundaries as much as possible wherever we can, and basically they can break the rules. So they are exempt from the population area and the population and area minimum and maximum rules, and they are allowed to cross county lines. So you'll see a fair amount of crossing of county lines on the map, but that's almost all the tribal areas. There are also two incorporated cities, Sedona and Apache Junction, that cross. So we did this in this order of hierarchy. So tribal lands, first and foremost, we're not going to change those. That was the boundaries we started with. Then we went to some of the big cities and looked to see how they've divided themselves internally. So we use that as a guide for City of Phoenix. They have villages, and they had that in the last decade, and they also have that now, and we've continued with that. City of Tempe has since developed character areas, much like City of Phoenix's villages, and we use those as a building block to build their PCAs. The most important layer, probably, even though it's last on the hierarchy, is the census designated places. This is defined by the 2020 US Census. It includes incorporated places as well as other settled concentrations of people that are identifiable by name but not legally incorporated. So any small town out there has a census designated place. It doesn't have to be just the big cities. All right, for the population compliance. So we were able to pretty quickly take all the census, or determine all the communities, then assign all of the census tracts to a community. And then from there, we needed to get them to fit our population compliance. We needed to approach it differently in rural than urban areas. In the rural areas, it was all combining because these communities were often quite small. So we used their proximity to other communities to try to merge those together to get to that 10,000 mark. In urban areas, they were often too big. So then we needed to split them up. So we used a tool. Last time it was called grouping analysis. This one, I already forgot, Nikki, what it was called, but she can help me with that in a second. But it's the way the tool works is it looks at all the census tracts and tries to merge them together based on 3 demographic variables: age, income, and percent minority. So using those 3 variables, it then tries to create a unit that is as heterogeneous or homogeneous internally and heterogeneous from the other communities that are built. Nikki, I saw you come on. What was the name of that?
Yeah, so it's a tool in our desktop GIS software, the spatially constrained multivariate analysis tool. And what it does is it clusters based on spatial constraints. In this case, it's just constraining it to areas that are adjacent to each other.
Yeah, that was easy enough. Yeah.
Yeah. At a high level.
Thanks, Nikki. Thanks.
Yeah, no problem.
Yeah, from there, we took those groupings and we tried to match them up somewhat with the zip codes that exist, because we're still trying to create these communities that match up with existing boundaries that people know. So like our Southwest Mesa one is zip code 85210 and 85202. This is basically the same thing we did as last time. It's just this tool is a bit of an improvement from the Esri tool that we used last time. Okay. And I should mention, when I say zip code, we're talking about the zip codes as established by the US Census. So US Census creates something called zip code tabulation areas every 10 years. And they are just a representation of zip codes at the point in time in which they make them, because as I told you before, zip codes are constantly changing. So that is what was used just to get us as close as we can to that area that would be recognizable for people. Okay, so of course there's always issues. Tracts do limit flexibility on what we're able to do. They have to be a certain size for the US Census. They have smaller groupings. They have a block group and a block. But our requirement from the feds is that we use the census tracts. So when doing that, you can see, like over here in the Navajo Nation and Hopi Nation, there's this section. Hopefully you can see my mouse. I'm not sure if you can, but there's this section to the left of Hopi. That's actually part of one big tract. So we weren't able to draw the Hopi boundaries exactly to where they are, because there's one big tract that intersects both Navajo and Hopi. So we had to determine which one had the highest population and give it to that one. So that's just one example of where tracts limit what we're able to do, because tracts are building blocks and we can't change the building blocks. So then the fixed methodology, of course, also restricts the use of local knowledge in favor of predefined rules. So there may be times when you can look at something and say, hey, I think this should go over here or this should go over there. But once you start doing that, it's a slippery slope and you lose your methodology, and it's hard to keep that, that consistency from decade to decade. The other disadvantage is that it must be updated every census, because every census, those building blocks, those census tracts, those change as well. So we need to change our boundaries with them. I will say, though, that is very stable compared to the other geographies out there, especially, let's say, zip codes, which change whenever there's a better way to deliver mail. So every 10 years changing is not too bad. And especially if you're using the same methodology, you have some consistency with that as well. Some facts about the PCAs. So we've got 139 of them this go round. In 2010, we had 126, so we did go up a bit. The average PCA has a population of 51,450 and an area of 820 square miles. There are 58 in Metro Phoenix, 20 in Metro Tucson, and at 181,121, the Phoenix Deer Valley PCA has the largest population, and Fort McDowell Yavapai Nation, because it's tribal, has the smallest with a population of 1,152. Okay, so this is an important slide for you. This is this shows an application that the GIS team built, and you can access it through that link that's at the bottom right. And once you get there, you can explore the 2010 and 2020 PCAs. You can click on the little magnifying glass and search for an address. You can zoom in and out with the plus and minus, and these pancakes here, you can click on that to view the legend. And then with this last button, you can turn the two different layers on and off. Okay, so next steps. We've got the PCAs built. What's coming next? From the statistical point of view, I do want to mention that we are building a public health data portal for the agency. This portal will allow us to put all of the data that we're able to publicly share in one place for anyone to access. One of the centerpieces of this public health data portal will be a data explorer. This data explorer will allow folks to find data at the PCA level, the county level, and the state level. Now, for this particular application, we're going to call them CSAs because we have found that the PCA name has been confusing for this type of user. So in this particular application, we're going to give it that name just to decrease that confusion and make it clear that this is how we're analyzing community. So it's community statistical area. So this will have the first rollout of this in June 24, and we're hoping to push the PCA/CSA idea across the state as much as we can and get others to start using it as a community level geography to do analysis by. So we'll try to get other agencies and anyone else throughout the state to start building data by this particular geography. And then we'll put it into this portal, not just ours, but other people's data too. So you could find a really rich library of data for each PCA if you would like to do analysis at that level. So let's see, this right here, this is our current data portal. We were able to build this with a grant from CDC, the Environmental Public Health Tracking Grant. This is a lot of what we're trying to do in terms of a data explorer for the public health data portal. However, it is only focused on environmental health, and we're really broadening that, and we're bringing that into all of our public health data and other data when appropriate. This one has the old PCAs in it. The new one will have the new PCAs in it. So look forward to that application. And if you want to explore it now, you can go to the link at the bottom right and explore our current ePHT Explorer. Another change that we're doing is in regards to the PCA statistical profiles. We will continue to create these just the same, but they are going to be found in two places. They'll be found on the primary care office site, but you'll also be able to find them in the public health data portal when that's built. We have another product called Quick Reports within the EPHT portal that does something very similar. We're going to unify those, and we're going to create some nice interactive reports that you can grab for each PCA. And that's all I've got. So,
Wes, Dr. Hardin had a question about what impacts there may be on ambulance certificates of necessity with the new PCAs.
I don't foresee any impact there. I don't think that these things are going to overlap. And you're just talking about like designations of CONs and that sort of thing?
Yeah, primarily that. Also, there may be issues about rate changes that may or may not be related to access CMS billing rates, which constitutes a rural or a PCA, where there's any bonus for operating in a particular underserved area. So that's kind of why I was asking. Thank you, Wes. Thank you.
Yeah. To my knowledge, I don't know of any relationship between the two things. I know that we have and are building rules for EMS in regards to how to determine response times and all of that sort of thing, but it's not using PCAs as its basis. So I don't think there'll be an impact there.
Thank you. Okay, yes. So you saw briefly, Wes showed the proposed new boundaries and how those are different than the 2010 PCAs. In a lot of areas, they're the same. In some areas, they've changed a bit. So we encourage you to go on to that mapping tool. Edith posted the link in chat, and to kind of play around and look around yourself if you're interested. We are going to have a public kind of feedback or comment period through December 29th. So if you have comments on those proposed new PCA boundaries, you can go ahead and go to this Google form link, or you can email workforce@azdhs.gov anytime before the 29th, and we will be sure to look at your input. Next slide. The timeline then is that we will have that comment period through December 29th. In January, we will look at any feedback. I'll also be doing a little bit of testing on, potential impacts to HPSA designations on some of those areas that have had more changes since the 2010 PCAs. And we hope to finalize the new PCA boundaries by the end of January. And then I will need to load those into HRSA's system by March 2024. This is actually great timing because while we've had this service area plan for a long time, HRSA is requiring all state primary care offices to create a plan and get it loaded in by March of 2024. So while other states are kind of coming up with their first plan, we're just doing a revision on ours. We've actually given quite a bit of TA over the past few years to other states too, who wanted to know how we did it. So I shared the methodology that we used last time with them, and hopefully that has been helpful. Once those boundaries are loaded into HRSA's system in March, then I will get busy doing a statewide assessment for HPSAs. So what I'm going to do is look at every single new primary care area in the state to determine whether it qualifies as a primary care HPSA, a dental HPSA, and or a mental health HPSA, and submit applications for all of those that qualify by fall of 2024. Normally, existing HPSAs just kind of get updated every few years, rescored, but because the boundaries are changing, I'm going to have to kind of do that like as if it was a new HPSA, basically. So all of our HPSAs will be replaced with new ones because our boundaries are shifting. And I will definitely keep stakeholders posted through that process as well, and the outcomes of those. Now I wanted to just take a few minutes to see if there's any questions from anybody.
I also want to add, Tracy, that if people have specific questions about anything on the map, I can pull up the application, the interactive application, and we can look through that if that's something that is needed. But yeah, any questions just in general?
This is Dave. Do you guys have a list of what types of providers fall under the primary care area? I know you mentioned dental, but what, like physicians, nurse practitioners, physical therapists? Is there a list somewhere?
So for primary care HPSAs, it's physicians only. In internal medicine, pediatrics, OBGYN, and family or general practice. For dental HPSAs, it's dentists. And also the number of hygienists and dental assistants they have kind of plays into how we calculate their full-time equivalency. For mental health HPSAs, we only look at psychiatrists. And those are all based off of federal rules for HPSA designation, which haven't changed in a very, very long time. So honestly, they're probably due for some updates, because now we know what a big role nurse practitioners and physician assistants play. But as you know, federal change takes quite an effort and lots of years. So maybe someday.
A tag-on question regarding the breakdown, particularly with the psychiatrists. Do you perceive the federal, as HRSA, I guess it would be, adjusting that definition of what constitutes that type of PCA, because of the fact that you've got clinical social workers out there, you've got sociologists, licensed psychologists, that help fill the gap, as opposed to just the medically needed psychiatrist. So I'm just wondering what your expectations are for change like that, help us with our shortages out there for services. Thank you.
Yeah, absolutely. So there are a couple different ways you can apply for mental health HPSA designation, and one does look at other types of mental health professionals. The problem is, if you do it that way, you have to survey all of those people, and we have pretty minimal resources that really barely kind of cover our surveys of physicians and dentists. So that would be so time intensive, because there's a lot of them, obviously. But the good news is, while the HPSAs themselves are based off of psychiatrists, other types of mental health professionals are eligible for the workforce recruitment and retention programs, like loan repayment. Any other questions? Or are there does anybody really want to take a closer look at a certain area on the map? If not, you can certainly look on your own and let us know if you have any questions.
I have another question.
Sure.
As you probably all know, I have a lot of involvement with transportation, ADOT, MCDOT, and some of the other regional CODs. A lot of times we're getting questions about like active transport, which is more or less a regional, local facility type approach. Do you foresee ADOT and the other regional councils and cities utilizing the new portal that Wes and your team are developing to help them develop and meet the needs of active transport from a public health perspective?
Good question. And one I don't know the answer to. I can say that I would hope so. I would hope that we can get more people using this as a unit of analysis, broadly. It'll be up to the agencies and all the other groups, organizations within the state, how they want to use them. but I will be proposing it as a level for community analysis that just doesn't exist right now. So a stable analysis unit at the community level that only changes every 10 years and has enough population to do analysis. That's a missing link out there in the analysis world. So I'm hoping that others will begin using it, and there could be many applications for it.
Wesley asked if you mind walking through a few of the changes in rural areas so they can get a feel for how it works.
Sure. Let's see. Let's turn on the 2010 so we can tell. Oh, oops, I turned it off. There we go. All right. Well, there's a lot that's the same. But if you look at, say, here in Cochise County, these differences are probably mainly due to a change in the census tract boundaries more than anything else. So that's pretty much the same. Santa Cruz is pretty much the same. There's a few changes down here, right? So Rincon and I think this is Summit are part of Vail rather than being in with the city of Tucson. Just a small change in the boundary of Sahuarita. Let's see, let's go to Yuma. Not a lot changed here. That's pretty close to the same. You can see the blue line, that's 2010, right? So there's a little change in Somerton. La Paz is pretty much the same. Mojave. The big change here is that we don't have Golden Valley anymore. We now have a new Kingman Butler and a Kingman. This used to all be Kingman, I believe, in 2010. That made for a very big PCA. But this time, the way it shook out, there is no Golden Valley. New Golden Valley is, I think it's part of New Kingman Butler now. We also now have a Fort Mojave and Bullhead City, which I don't know if we had separate ones before. Yeah, they were the same before. So this just growth made that happen. It's been a lot of growth in this area. And remember, our threshold for new communities is 10K. In the past census, a lot of these units did not reach 10K and had to be merged. Now we've had quite a few get over that hump, right? And we have a few new areas within the Prescott metro area. Navajo and Apache are pretty much exactly the same. Greenlee's the same. We did merge in Safford with Thatcher. So the Graham County area is all one with the exception of the tribal areas. And then there's some changes, of course, in Pinal County with all of its growth. These in Santan, that's just a change in tracks more than anything else. It shook out this time so that Saddlebrook in this area became the same. And let's turn off the Saddlebrook Oracle. Eloy is now this much smaller area here in terms of area, but it's much bigger in terms of population. Maricopa and Casa Grande kind of swapped this space, but hardly anyone lives there. A lot of the changes that occurred are areas where there's not a lot of people, or there has been a recent change in the number of people that are there, right? So this probably isn't going to make a huge difference, this space for Maricopa and Casa Grande. It'll make some, but most of the populations are in these two areas, not as much down here. Buckeye now has its own PCA, where it didn't last time. So Gila Bend is on its own, and Buckeye has its own. Wickenburg has been separated from Surprise. Those used to be merged together just because of the population was too low in Wickenburg. So I think a lot of positive movement in terms of being able to separate some of these communities out that should probably be on their own, but they just didn't have the population. But now Wickenburg does. Now all those areas up in the Prescott area do. So overall, I think it went pretty well. The for our rural areas. Is there any other specific areas you wanted me to look at?
One thing to point out with the Phoenix villages is with Maryvale.
Yes.
This time it was actually too large, right? West above our maximum.
Over 200,000, so we had to split it. Maryville's a very big area.
Yep. So other than that, the city of Phoenix will look the same, basically, but Maryvale is split.
Yep. So this was all one before, now it's split in two. Another rural change is Donnie Park is now separate from Flagstaff. Let's see, there it is. So that is over 10K in that area, so it has its own.
A couple questions came in. If all existing new PCAs are evaluated by fall 2024, when will new HPSA scores be effective? So, Tara, I'll get the applications in by then. HRSA then has to do their process of reviewing and approving those applications, which can take a few months typically. That'll be a busy time because all the states are doing this. So it could maybe even be up to 6 months. But once they finish their review, then that score is effective immediately as far, once it's approved and published on their website. And then how will county health departments adapt their respective outreach and service delivery with the new changes? I'm not sure if the county health departments use these areas. I think it would be great if they do, but I don't really know. Have you heard of that, Wes?
In the past, Maricopa County has taken some of our areas and merged them together into bigger areas to slice up Maricopa County for different studies. There's some use out there, not a lot, not as much as I'm hoping there will be in the future with these.
Are there any other questions or any other areas anybody wants to zoom in on? Okay, well, you all have the links, so we encourage you to go ahead and take a look at your own communities. If you have any feedback, please go ahead and submit it on that form, which I think is also linked in the chat. Yep, Yahira put the form link as well. We will send out the recording and slides, and it'll be posted on the primary care office website also. And is there anything else I'm missing? I don't think so.
I think you got it.
Yeah. Okay, great. Well, thank you everybody for joining us. Thanks, Wes and Nikki, for all your hard work on this. It's been a huge project and we appreciate it.
Quick question.
Yeah.
When will the recording and the presentation be made available? And how do we get it?
Yeah, good question. We should have it. I'm just going to talk on behalf of everybody. It should be available pretty soon, and we can email it out to the attendees.
Thank you. I want to share
that should happen pretty soon. I don't know about posting it on the website. I'm not sure how quickly that goes.
Sometime before Christmas. Okay. I want to share this presentation with my supervisors and my bureau chief, and this is fantastic information. I see a lot of interagency and intra-agency opportunities with this project. I mean, I've always been impressed with Tracy and Russ's work. They're great when it comes to this stuff. So thank you all very much.
Awesome. Thank you. Yeah, definitely. Once we send it out, please feel free to share it with anybody who might be interested, because we want to make sure that we get any comments now while we're still finalizing the boundaries. So, okay, with that, we'll give, oh yeah, Wes.
David, I'm happy to talk to you about this more. It does pair in with a lot of our data modernization initiatives. One other thing I think I will mention is that for the agency, every bit of data that we have that has an address, we're going to join the PCA to it. So all of our data in the whole